All right, this is a video lecture on potassium homeostasis. So let's get started. Here are the objectives. Talk about homeostasis, then the membrane potential, hormonal regulation, and then how the kidney handles potassium and how we can affect it with medicines. So, like everything else in renal physiology, it's all about balance. And so for potassium balance, homeostasis is achieved when whatever goes in equals the amount that goes out. And so we get problems when the potassium that is going in does not equal the potassium going out. So I want you to keep the balance concept in mind. So in normal situations, this is what normal potassium balance looks like. Remember, most of the potassium in our body is in the intracellular fluid. So intracellular fluid is very rich in potassium. So you can see in relative amounts, that's where potassium is living. How much is in the extracellular fluid? I don't know, maybe 65 milliequivalents in your entire body. In a normal diet, you may take in maybe 100 milliequivalents per day. And, some of the famous foods that are rich in potassium, like, citrus, so orange juice, bananas, beer has a little bit. And so if we take in 100 milliequivalents per day, in order to stay into balance, we should excrete 100 milliequivalents per day. And guess what? That is identically the amount that we excrete per day through the kidney, and we do lose a little bit through gastrointestinal secretions because those secretions are kind of rich in potassium. Okay, so in order to stay into balance, we'll take in about 100 and we'll excrete about 100, tiny amount in the stool, and then the kidney is going to handle the rest. Just to reiterate, the composition of fluid inside cells and outside of cells. So inside of cells, it's a lot of potassium. How much? About 150 milliequivalents per liter. Compared to plasma and interstitial fluid, it's about 4 milliequivalents per liter. The normal range for plasma potassium is usually given between 3.5 and 5.5 milliequivalents per liter. Okay, let's do a case. 62-year-old woman, she has end-stage kidney disease, so she has no kidney function. She's been having leg weakness. You can see her vital signs here. She's quite hypertensive. She's confused. She has a bradycardia on exam. You can tell that her heart's really slow. And this is she has a catheter in her leg. This allows access for dialysis, and she can't move her lower extremities. You can see her labs are remarkable, mainly for a serum potassium of 9.8. Okay, that's millimoles per liter. Remember, the normal is 3.5 to 5.5, so this is markedly elevated. Her EKG is abnormal. Remember, we said from your physical exam, you can tell she has a bradycardia. And here, this shows a pretty profound bradycardia. For every QRS complex, I do not see a P wave, and the QRS complexes look pretty wide to me. So this is kind of a wide complex bradycardia. This looks like a complete heart block. All right. And, if we look at the spectrum of EKG changes with respect to the serum potassium, this makes a lot of sense. So hers is around 9 milliequivalents per liter. And what we would expect to see on an EKG would be essentially heart block and intraventricular block with a very wide QRS. So something's wrong with conduction at the myocytes, okay? Because look, down here with a normal serum potassium around 5, you can see we have P waves. We have a shortened QRS complex. What's going on? And why is there this progression here? And you can see that if we do nothing, if the serum potassium goes higher, we eventually get ventricular fibrillation. And we want to avoid that because that is obviously life-threatening. Okay, so in this patient, she got emergency hemodialysis. So dialysis was done. It took away all that potassium. Now her potassium is 5, and look at her EKG. This is the exact same patient. An EKG was done 12 hours after the presentation. And look, now I see P waves, QRS is narrow, and obviously the heart rate is better. So this is quite instructive, and we do see this clinically from time to time. So what do you think is happening? So the main question, why does a potassium of 9 cause this, whereas a normal potassium causes this? Let's answer that question. It all has to do with the resting membrane potential. Okay, so excitable cells are highly dependent upon this resting membrane potential. Okay, The net effect of on the resting membrane potential is that the cell interior is negative with respect to the outside the cell, okay? So inside the cell is negative with respect to the outside. And why is that? Well, here's why, okay? So because we pack the cell with potassium, right, there's a lot inside, but there's not a lot outside. There's a chemical gradient for potassium to leave the cell, okay? Remember, there's also this gradient for sodium. There's a high sodium concentration outside the cell, very little inside the cell. So there's a chemical gradient for sodium to want to come inside the cell. All right, but here's the kicker, is that for excitable cells, to set up the resting membrane potential, there is always potassium leak from inside to outside the cell. So as long as potassium is able to leak from in to out, and as long as we're spending energy at the sodium-potassium ATPase to continually be pumping potassium in and sodium out, we can maintain that gradient. And so as potassium wants to leave the cell, it generates a negative potential difference. So this interior is negative with respect to the outside. So essentially, whatever ion can leak across the membrane, that's the one that contributes to the resting membrane potential. Now, I was talking about sodium earlier. Well, guess what? At rest, sodium can't really cross the membrane. Okay, sodium will only cross the membrane when sodium channels are activated. So at rest, very little sodium will move from outside to inside. So does it contribute much to the resting membrane potential? No, right? So as sodium would move in, you'd expect the resting membrane potential to get more positive. So that's not happening, but is potassium diffusing out? Yes. So as the potassium diffuses out of the cell, it makes the interior more negative. And this is what maintains our resting membrane potential at this negative range of negative 70 to negative 90 millivolts. Okay, so now let's bring this full circle and talk about sodium channels on excitable cells. So at rest, sodium channels are deactivated, they're closed. So none or hardly any sodium is going from outside to inside the cell. What's running the show here is potassium, because potassium is leaking from inside to outside, and that will make the interior of the cell negative with respect to the outside. So at rest, at the resting state, the membrane potential is very negative, negative 90 millivolts, because potassium is the thing running the show. Okay, now when the sodium channel, this voltage-gated sodium channel is activated and open, well, now sodium is running the show. So now the cell is depolarized as sodium, which lives outside cells, rushes into the cell. The membrane potential gets very positive. We call that depolarization, okay? But we don't want to just do that all the time. So the voltage-gated sodium channel has this safety valve that will close. So when the gate is inactivated, it's closed. No more sodium is moving. And now we can repolarize the cell by making sure that we pack the interior with potassium. Now potassium will leak across and bring the resting membrane potential back down to minus 90. That is what allows this this voltage-gated sodium channel to be ready to fire again. So in order to move this inactivated closed channel to a closed channel that's ready to fire again, you have to repolarize the membrane, because these are voltage-gated channels. All right, so the forces at work: potassium is packed inside the cell and wants to leak out. That's what keeps the resting membrane potential negative. And the reason we had this is because the cells have these potassium leak pores, okay, at rest. And then sodium lives outside the cell and wants to come into the cell, but we only let it come in at special times, only when the voltage-gated sodium channel is active. So we can use math to actually determine what the resting membrane potential should be for various potassium concentrations. And so the equation is the Nernst potential, or the equilibrium potential. And you probably heard about this in your chemistry classes, and it's incredibly instructive, especially as we talk about potassium in that patient who was very sick, who we just dialyzed. All right, so this is the equation, the Nernst potential, so named after Walter Nernst, who formulated this. And so essentially we're trying to ask the following question. We're saying, what is the equilibrium potential across a membrane that is permeable to ions, and what would be the concentration of those ions inside or outside the cell that is driving this equilibrium potential. So you plug in the concentrations of the various ions, and we plug in some constants, and it gives us the equilibrium potential, okay? And so this is all dependent on how permeable that membrane is to those substances, okay? So let's take a closer look. So remember, some of these constants, R is the universal gas constant. Temperature, we throw in, normal temperature in Kelvin. Z was the valence. Remember all these constants, Faraday's constant. So the main takeaway here is that we can sort of boil that down to this term, this minus 61, assuming we're at ambient temperature. Now, keep in mind, the things that drive the equilibrium potential would be the relative permeability of the species that we're looking at. And so really the things that's driving the show at resting state is potassium. So really the potassium terms, the concentration inside the cell and outside the cell, that's what's really going to drive our resting membrane potential. Sodium is here just for completeness sake, but look, the relative permeability of sodium to potassium is about 0.01. So we put a 0.01 factor here on the sodiums, and basically these terms are quite insignificant. What really drives it is potassium, and that is why serum potassium could cause all those problems in excitable cells like the heart. Okay, so let's just do an example. All right, let's throw in some normal numbers, what we think we would see based on what I showed you on a normal plasma concentration. So remember, the amount of potassium inside a cell is 150. Let's say normal potassium concentration in plasma, let's just say 4. Okay, normal intracellular sodium, let's just say around 4, and then normal extracellular sodium around 140, let's just say 142, all right? So sodium, remember, it's impermeable, it's not very permeable across the membrane, so we use this 0.01 factor here, okay? But really what's driving the show is potassium, all right? So let's do minus 61 times the log of essentially 150 over 5.4. What does that come out to be? About minus 87, so pretty close to minus 90 millivolts. Okay, so this gives you an answer in millivolts. So at normal physiologic concentrations of potassium, you can see that an excitable cell would have a resting membrane potential right around negative 90 millivolts. Okay, so here's why this is important. So here we are at the resting membrane potential, which is minus 90 millivolts. So for an excitable cell, remember, let's just take the myocyte since we're thinking about the heart. At rest, it's resting. It doesn't need to beat. But you have to have some kind of control. You have to be able to say, I want to depolarize now and then rest. Now, rest. Depolarize now, rest. So the way we do that is those voltage-gated sodium channels, they have a threshold, okay? And that's good because you don't want them on all the time. Otherwise, the whole system wouldn't work. And so there is a depolarization threshold, and when the membrane potential increases to the point where you hit the threshold, well, then you get a big depolarization event, and that's when those channels are temporarily open, allowing sodium to rush in. So one thing to keep in mind is the distance between our resting state and threshold state. All right, distance between resting and threshold could have clinical significance, and let's talk about that. Now, let's run the math again, but let's increase the extracellular potassium. Let's say now we've introduced some kind of a problem, some disorder, and now the patient has a high serum potassium concentration. Let's redo the Nernst equation, okay? Same equation, all right? So intracellular potassium, 150 for the moment, okay? We haven't done any shifting yet. Let's keep intracellular and extracellular sodiums the same as before, but remember, they don't really contribute much because of this relative impermeability at rest. But look, we increased extracellular potassium. It was 4 in the last example, now it's 6. All right, let's redo the math. All right, so minus 61 times the log of 150 over 7.4. Okay, so now it's minus 79 millivolts. All right, and so in parentheses, this was our last case, which was minus 87 millivolts. So by increasing extracellular potassium, you can see that our resting membrane potential became less negative or more positive or more depolarized. Those are all just synonymous. So it became less negative. It became more depolarized. Okay? Now, look at this. So hyperkalemia, increasing the extracellular serum potassium, will depolarize the resting membrane potential in excitable tissues. Instead of sitting down here by minus 90, a resting membrane potential much higher will get us closer to threshold, okay? And let's go back to that case, right? Remember that woman had a serum potassium of 9.8 milliequivalents per liter. If we do the math on her resting membrane potential is like minus 68 millivolts, right? We're so close to threshold, depolarization threshold, okay? So once again, at rest, we're closer to minus 90, but with hyperkalemia, we slowly inch up towards the threshold, okay? Now, here's the kind of confusing thing that I'm going to explain right now. I've had students say, well, oh my gosh, if it's more depolarized, wouldn't the heart be more active, like, tachycardia? Wouldn't conduction be enhanced? So I'm not saying depolarization, is occurring more swiftly or strongly. Think about this. As we depolarize the resting membrane potential, fewer sodium channels are now going to be reactivated to fire again the second time. Okay? Remember, the sodium channels need to go from the active to the inactivated state, and then eventually they're ready to fire again. That process occurs by repolarizing the resting membrane potential, by coming back down to minus 90, okay? If we sit up here, if we hang up in a depolarized state for too long, we will have fewer sodium channels that are ready to fire the next time. This is the key point. For something like the heart or a nerve, you want it to fire, but you want it to repolarize so you can fire the second time, okay? So that's important for the heart because it beats a bunch, right? It's beating multiple times in a minute, and you need that to maintain a blood pressure and good cardiac output. So my point is, if you depolarize excitable tissues and stay depolarized, you're not going to be able to recruit enough sodium channels for your next beat. What's the consequences of all this? Decreased conduction in excitable cells. So look, here we are normal. We have a good PR interval. We have a normal QRS. As we increase the serum potassium, we start to prolong PR interval. Look, we widen our QRS. We start to actually lose conduction, and it becomes so disorganized it can turn into ventricular fibrillation. Okay, so depolarizing the resting membrane potential is not good for conduction. It slows conduction. Okay, all right. How do we avoid all this stuff? We're going to talk about how we regulate potassium homeostasis. There's two main categories. There's internal balance and external balance. External balance is sort of how we regulate total body potassium through how we absorb and excrete potassium. And then there's this concept of internal balance, which is where we can regulate the distribution of potassium between inside of cells and outside of cells. Because I just showed you that it's important in terms of the quantities in and out of cells. Well, our body can move it back and forth to try and help regulate extracellular potassium concentrations because I just showed you that it's important for excitable cells, okay? Real quick, just another case. An older woman was found unconscious at home. You can see her temperature is very low, 21 degrees Celsius is extraordinarily low. She's hypotensive, she's bradycardic. GCS is the Glasgow Coma Scale. It's essentially a measure of how well her brain is working and is not working very well at all. She's intubated, which means she has to be put on a artificial breathing machine. Okay, so the main thing to take away on a blood gas and serum chemistries, her serum potassium was extraordinarily low. It was 1.1 milliequivalent per liter. Okay, on a separate measurement, it was 1.6 milliequivalents per liter. So this again is a very real case. Here is her EKG. So you can also see a marked bradycardia and hopefully appreciate a very wide QT interval. All right, so there's a prolonged QT, bradycardia, and she's hypotensive, so clearly something's wrong with her heart. Okay, all right. So what happens with hypokalemia? So her extracellular potassium is extraordinarily low. Well, let's just do the inverse of what we did with the last case with hyperkalemia. If hyperkalemia depolarize the resting membrane potential, hypokalemia will hyperpolarize the resting membrane potential. So hypokalemia hyperpolarizes excitable tissue, so it pushes the resting membrane potential way down here. It pushes us farther from threshold, so it's going to make us more difficult to hit the threshold and open those sodium channels. Okay, so it can also cause bradycardia and cardiac dysfunction, but sort of through a different mechanism. We're now hyperpolarized. We're too far from threshold to hit it, so we're going to hit it less often. All right, so the interesting thing with her is that she was basically hypothermic, and apparently it was a very cold winter, and she couldn't, afford good heating in her house, and maybe fell asleep and got incredibly hypothermic and sick. So the unique thing here is that with hypothermia, there's a very rare redistribution of potassium from extracellular to the intracellular compartment. And so this was all just due to shifting, all right? It's not that she was low in total body potassium, but through hypothermia, through unknown mechanisms actually, extracellular potassium was shifted into cells, okay? So just by warming her, the potassium improved. Look, now it was 5.1. Her serum potassium after she was warmed, and so this is quite interesting, quite instructive. So, so if not recognized, it could be dangerous if you administered a lot of potassium to someone who is hypothermic. Apparently, the teaching here is rewarm the person if they're incredibly hypothermic before administering potassium. So, so it's really interesting. So, but it makes us think about this internal balance issue. Okay, so let's talk about internal balance, and this is how potassium can shift from extracellular fluid to intracellular fluid. Like, how does it go back and forth? What are the things that regulate it? And why do we care about that? Okay, first, this is the moment-to-moment control of the extracellular potassium concentration. So I want you to think about that Nernst equation. Remember how it's intracellular potassium over extracellular? So think about the numerical change in one or the other. Which one has the greatest impact on the resting membrane potential? It would be the extracellular. So potassium inside of cells is 150. If I go from 150 to 152, would that impact the RMP very much? I don't know, probably not. Maybe you should do the math and figure that out. All right, now what if the extracellular potassium goes from 4 to 6? Well, we just did that math, and it showed a marked change in the resting membrane potential. So extracellular potassium has that greatest impact on the resting membrane potential. So we definitely care about it, and we'll shift potassium in and out of these compartments to keep it copacetic, okay? How do we do it? Well, we can stimulate the sodium-potassium ATPase, okay? And then also there's some cellular potassium secretion mediated by potassium channels, okay, that can determine the permeability across those cells. So we got two buckets. So right now we're talking about internal balance, how potassium shifts in and out of cells. We got hormonal factors and we got environmental factors. We're going to go through each. Hormonal factors includes insulin and catecholamines, okay? And the environmental factors, the pH, essentially acid-base disturbances, plasma tonicity, which we're going to talk about, and embodied temperature, which that case just illustrated, where hypothermia causes lots of potassium to shift into cells and the extracellular potassium would be really low. All right. Broken down with a little more detail. So what are the things that will shift potassium into the cells? Insulin shifts potassium into cells, beta agonists, okay, and exercise by action of circulating beta agonists like epinephrine, so catecholamines. Metabolic alkalosis, so a high pH will shift potassium into cells. What about the things that will pull potassium out of cells, make it shift out of cells? So high tonicity, and the classic example is hyperglycemia, and the mechanism we cite here is solvent drag. So hyperglycemia or hypertonicity outside of cells will pull water. There'll be water movement from the cell, and that can drag potassium with it. Remember I mentioned beta agonists will make potassium go into cells. Well, if I'm blocking beta agonists with a beta blocker, that will facilitate potassium moving out of cells, or like I said the other way, it prevents potassium from being shifted into cells by catecholamines. Also, what if those cells are dying, right? So anytime a cell lyses or dies, it's going to release potassium. That's one mechanism. And then a metabolic acidosis, a low pH. And we're going to get into this. First, insulin. So this is key. Insulin will stimulate cellular uptake of potassium just by increasing sodium-potassium ATPase activity. So it's a hormone, you give it, and it will increase sodium-potassium ATPase and cause cells to take in potassium. So insulin and potassium are components of this loop, and it will help bring potassium into cells, and we do this therapeutically. Okay, so if we ever need to shift potassium into cells, move it from the extracellular to intracellular fluid, we can just give an IV dose of insulin. Next, catecholamines. So epinephrine, whether we're giving a catecholamine or whether it's through exercise, catecholamines will stimulate potassium uptake into cells. Now, this graph is showing you basically the consequences of blocking that. What if we gave propranolol, a beta blocker, right? Look, through exercise and then even through recovery, the change in plasma potassium was greater when we administer the beta blocker. Okay, that means that in the control portion, in the control cohort where we did not administer a beta blocker, there was a lower change in serum potassium. So that change was mitigated by shifting into cells. So it's kind of cool. So they're giving catecholamines that also will shift potassium into cells, and basically beta-2 adrenergic receptors increase sodium-potassium ATPase activity, and this is sometimes used therapeutically. We don't use epinephrine in the clinical settings, but we use inhaled albuterol, which is has beta-2 agonist activity in the lung. So we don't want to give it systemic because it would cause a lot of side effects to give a catecholamine that way. But sometimes we use inhaled albuterol, and that can help shift potassium into cells. Okay, so this is pretty important because I think this can help you solve other problems in renal physiology. So acid-base balance. So think about this. Changes in the extracellular pH will produce these reciprocal shifts in potassium and hydrogen ions between the two compartments. And so I want you to imagine on our cells this happening. So if there are excess protons outside the cell, they can shift into the cell in exchange for potassium. So there's always this give and take of protons for potassium in order to keep things electroneutral. So if there's too much potassium outside of a cell, we can put it into a cell, but it's going to kick out a proton. All right. So the driving force could be potassium gradients, or it could be protons. So let's just talk about acid-base balances here. So in acidemia, let's say there's a metabolic acidosis, there's too many protons. All right, so protons are building up outside the cell. So to mitigate that, to buffer that with intracellular buffering, let's move protons into cell, but it's got to kick out something, and it kicks out potassium. Okay, so one of the consequences of an acidemia or acidosis could be a rise in the extracellular potassium. All right, likewise, what if there are too few protons outside of the cell? Like in alkalemia, a metabolic alkalosis, there's too much bicarbonate, too few protons. Well, the cells can pump out some protons, but it's got to exchange it for something. And what does it exchange it with? Potassium. So this will facilitate potassium movement from the extracellular fluid to the intracellular fluid in exchange for that proton. I also mentioned the plasma tonicity. So changes in plasma tonicity can cause fluid to shift from the intracellular compartment to the extracellular compartment. And the classic example would be hyperglycemia. So someone who's very, very hyperglycemic, because immediately glucose won't move into the cells. And so if glucose is building up outside of cells in the plasma, it can produce hypertonic fluid compared to intracellular fluid. And so, at that moment-to-moment basis, water, which can cross membranes, will start moving from the intracellular fluid to the extracellular fluid. And apparently, as part of that process, potassium will start to exit as well. And so when potassium exits along with water, we call it solvent drag. And so this is another way for potassium to move from inside of cells to outside of cells.